on? Yes, okay. I want to welcome everyone on this chilly but bright day where we're going to hear a very bright program, I think, and something that will enlighten us about the state of our health care. Before we do that, I want to have our customary 2-minute tidbit that gives
only
us
2 minutes today.
that gives us our kind of grounding in our local community. Jeff?
All right. Again, with the interest of tying all three communities together, we've had, last month we had cemeteries, we've had rivers and creeks and so on. Today's topic is parks. And there's so many, we're blessed with so many parks that I'm only going to do one at a time. So today is the Village of Mamaroneck. For example, Larchmont has 10 municipal and 1 non-municipal park. Town of Mamaroneck has 93 acres of parks and grounds. The Mamaroneck Village has 13 municipal parks and 1 non-municipal. So right away we know about Harbor Island. Everybody knows about Harbor Island. Even the people in the village of Larchmont know about Harbor Island. Number 2, Columbus Park. People know where Columbus Park is? Along the railroad station on the north side of the tracks. A great park where the 2 rivers meet, so don't go there when it rains heavily. 3, one of the best parks in Mamaroneck is Florence Park. I don't know how many people know where Florence Park is, but it's in Rhinebeck, and it's got 2 tennis courts, it's got 2 full lighted basketball courts, it's got a 1/3 of a mile running track around it. It is a fabulous park that hardly anybody knows about. Number 4 is Stanley Avenue Park. That's along Stanley Avenue and Fenimore Road. If you go down Fenimore from Palmer Avenue. 5, Gillies Park. How many know where Gillies Park is? That's the triangle when you go in Orient Avenue and it splits off with Rushmore. That's Gillies Park. I remember her. O'Connell Park. This is on Phillips Park Road. Phillips Park Road, by the way, for those who don't live in the village of Mamaroneck, is that road behind the stores on Mamaroneck Avenue. And there's a little area there where there's a couple of tables that have checkers and chess on top of it. Okay?
Okay.
7, where is 7? Jefferson Avenue Park at North Prairie Avenue, playground apparatus, 1/2 basketball court near the railroad bridge. 8, Pate Memorial Park, next to Terrytown 2 on Old White Plains Road in Madison. It's a nice little sitting area. We are blessed with little pocket parks. 9, Ward Avenue Park, playground apparatus, Ward Avenue and Spencer Place. That's where Ward Avenue comes down from Melbourne one way, and there's a little park there before it hits Spencer Place. I can see a lot of people don't know what the hell I'm talking about, where it is. 12, this is one of my favorite parks, Warren Avenue Park. How many people know where Warren Avenue Park is? If you go up Mamaroneck Avenue to the Heights, and you turn right on Warren Avenue, and go down towards the end, it's an absolutely stunning little park, a jewel. It's got a river running through it, tennis court. It is one of the hidden places. Park there on a weekend and take a walk. So, Bub Walker Park. That's at the end of Grand Street and Plaza. And it's got a bocce court, a little gazebo, and you can walk from there all the way to Fenimore Road, where the thruway bridge is. It's an absolutely wonderful, stunning park. Pate Memorial Park, I did that one. Stanley Avenue. All right, one of the best parks is a non-municipal park, and that's the Otter Creek Preserve. And that is 27 acres with a half-mile loop owned by the Nature Conservancy. And it's bounded by Shore Acres, Greenhaven, Van Emmerich Mill Pond. If you go down Taylor's Lane, anybody know where Taylor's Lane is? One of the best little streets. It's down short of Toyota. You turn right, there's a little gas station on the corner. You go down and you find some absolutely wonderful scenery. If you go down all the way to the end, you see Long Island Sound and Van Emmerich Mill Pond and Mamaroneck Harbor. But halfway down, There's a little parking area. You can walk into the preserve. It is 27 stunning acres going from Long Island Sound almost to the Post Road. And people don't even know it's there. And of course, I save the best for last because we're blessed with pocket parks. The best for last is Megan Park. True. Megan Park is behind the Chase Bank on the corner of the Post Road and Mamaroneck Avenue, given by my grandfather in the early 1900s. Thank you very much.
Thank you, Jeff.
Who is Gillies?
Thank you, Jeff.
Very nice lady.
As is our custom, we're going to send this around to have everyone announce who they are, where they're from, and what they represent in terms of any organization. So, you know what? Okay. You're right. Okay. We want to make this quick, but we want the speakers to know who is in the room as well as everyone else know who their neighbor is at this meeting. Elaine Chapnick, President of the local summit.
Amy.
Ooh, feedback. Go ahead, just say it.
Amy Winkler, Mamaroneck. Shirley Hilton, Mamaroneck Village. Lynette C., Local Summit Board.
Sabrina Fiddleman, Local Summit Board, LMC-TV, and the Larchmont Mamaroneck Undercast.
Turn it on, see if it's on. Is it on?
It's on.
Okay, just for my game.
We just use Long Palace.
Yeah.
Malcolm Froman, I live in Larchmont. I'm the recently named president of Larchmont Mamaroneck Hunger Task Force.
No, this one isn't connected to that. It's connected to the television. That's why we have this.
That's why you're here. How I know about it.
Kate Moody, several decades in Larchmont, just now moved to Mamaroneck. Janet Macy, continuing ed with Board of Assessment Review.
Jeff Megan, Mr. Tidbit, Summit Board and LMC-TV Board.
Ernie Odierna, Deputy Supervisor and Councilman, Town of Mamaroneck.
Linda Kalos, Town of Mamaroneck. Emily Michelle, Summit Board, and Don Bosco Brooklyn. Jane Orion, Summit Board, and Community Counseling Center.
Peter Cohen, Mamaroneck.
Fran Senator, Village of Larchmont. Marlene Colbert, trustee of the Village of Larchmont, and don't forget to vote if you live in the village today. And with a husband who spent 45 years at Montpelier.
John Gitlitz, Purchase College, Summit Board, Hispanic Resource Center, and Don Bosco Worship.
No, they were just speak up.
David Chapnick, Village of Larchmont.
Nada Glick, Village of Mamaroneck, and Human Development Services of Westchester in Mamaroneck.
Mike Reichott, Village of Larchmont.
Lynn Reichstadt, at home on the Sound.
Mike Rosenbaum, Mamaroneck.
Lois Hillisberg, at home on the town.
Elizabeth Sanger, Summit Board and Human Rights Committee. Bob Sanger, Mamaroneck.
Judy Dabra from Kansas, person with a very close connection to Montpelier Jewish.
Richard Allen, I'm on the Summit Board and I'm the pastor at Mamaroneck United Methodist Church until June the 30th at midnight.
But who's counting?
Kay Francis, Human Rights Committee and the Summit Board. Ann Bukowski, St. Augustine Church.
Bob Hayden, Summit Board, and at home in the Sound.
Mary Barrage, $8 money. Don't forget, and do sign up. We'd really like to get your emails to help you hear about other meetings. So please, it's going around. And I'm on the Summit Board.
And whether you have breakfast or not, it's $8 a head because they count and charge us. So please, eat, right, right.
Anyone who has to visit me, I'd be so happy to visit.
Yes.
Susan Riley, Mamaroneck Public Library.
Tanya Stack, YMCA of Rye.
Dennis Steen, YMCA of Rye.
Lois Steinberg, Center for Aging in Place and At Home on the Sound.
Alan Epstein, Mamaroneck, volunteer at Montefiore, the Caregiving Support Center.
Yvonne Trupp, board member, Mental Health Association, volunteer for CASA, court-appointed special advocates for foster children.
Doris Block, Summit Board, Hunger Task Force Steering Committee, and Town of Mamaroneck Traffic Committee.
Nina Resio-Cuddy, Summit Board.
Penny Oberg at Home on the Sound.
Carolyn Pomerantz, Summit Board, LMC-TV, thank you for filming us aboard, and the League of Women Voter Boards, both county and local.
Irish Free Hope Community Services.
Oh, here. John?
John.
No mic.
John Bradley at Home on the Sound
Nancy Pierce from
and
Mamaroneck.
Summit Board.
Nancy Pierce from Mamaroneck Board of Education.
Stephen Martell, President of Rotary Club of Larchmont, Mamaroneck Hunger Task Force.
Carl Berman, I'm an attorney, I live in Mamaroneck and I work in White Plains.
Nancy Sellenson, Mamaroneck Town Supervisor.
Janet Buckbinder, Summit Board, and Radar.
Abby Katz, Town of Mamaroneck Councilwoman in food safety.
Jane Altabini, Councilwoman, Town of Mamaroneck.
I think that's it, right?
I know.
Who? I'm sorry. Would you introduce yourself? Last person who walked in? Would you introduce yourself, please?
I'm Ariel, I'm a resident of New Rochelle.
Okay, thank you. Okay.
I'm a member of the League of Voters.
As you see, we have a representative of most of our nonprofits and community leaders here today. I will give the program over to Nina. There you are. To introduce.
I'm gonna try and do this, can I do this without the mic, or do I need the mic?
You need the mic.
I need the mic?
Definitely.
I definitely need the mic. Okay. First of all, I want to thank everyone for coming today, and I must especially want to thank our guests. I'm going to read because I will never remember everything about them. To the far left is Dr. Andrew Racine, and he is an MD, PhD, and the Senior Vice President and Chief Medical Officer of the Montefiore Medical Center, and he's Executive Director of the Montefiore Medical Group. He's a graduate of Harvard. He also is a graduate, he has a combined degree in medicine and economics from NYU. I need glasses. Oh, that's what it says. He trained in pediatrics at Boston Children's Hospital and served on the faculty of Columbia University College of Physicians and Surgeons. He became the Associate Director of the Division of General Pediatrics at Albert Einstein. Is that correct? And has served as the director there from 1997 until August 2012, when he assumed his new positions. He's been heavily involved in children's health advocacy on the national level with the American Academy of Pediatrics, and he will be able to explain, I think, a lot about what's happening with Montefiore. Next to him is Lynn Richmond, and Lynn is the Senior Vice President and Chief of Staff for the President and CEO at Montefiore Medical Center. She's responsible for government relations, community health, and strategic planning. And she serves as senior liaison to the leadership of organized labor and oversees board relations for Montefiore. She's a nurse practitioner, has a bachelor's degree in nursing from Columbia, a bachelor's in anthropology from the University of Michigan, and a master's degree from Hunter College. And she is a member of the Montefiore Einstein Center for Bioethics and teaches at the college, the medical college. And I don't have a complete bio here, nor do I have the card right now, for Anthony Alfano, who is the Executive Director, Vice President of Montefiore New Rochelle. It's no longer Sound Shore. We've always talked about Sound Shore, but it's Montefiore New Rochelle. And we are, I think everyone in this room has a doctor or has had a doctor who is either affiliated with Sound Shore or White Plains. And this is a matter of personal concern to so many members of the community. So we welcome you, and we appreciate you taking the time to tell us how our healthcare will be hopefully heightened and improved by this collaboration. Thank you. And
I'm not sure. I'm not going to talk into this yet.
Good morning. Thank you, and thank you for inviting us here this morning. We're very happy.
Louder, please.
There we go.
I've never been known for my booming voice, so we're very happy to be here this morning, and delighted that you invited us. We came in part to really update you a bit on what's been happening, and I think what you had asked is around what's been happening at the Montefiore New Rochelle campus and the Montefiore Mount Vernon campus. But we really hope that this marks the beginning of a dialogue and an ongoing dialogue. Montefiore has a long tradition of working closely with its communities and getting input and feedback and working together. So I'm going to tee it up a little bit just to sort of give you like a brief primer, if you will, on Montefiore. And then I'll turn it over to my colleagues, here, and then I hope we can really have a bit of a back and forth. I think the bulk of what we'd like to do is really maybe answer your questions, address issues of particular concern to you. So Montefiore is an academic health system with our partner, the Albert Einstein College of Medicine. And in 2009, we really made a decision to strengthen the work that we do with the college. We have a long history of working with the college, but we decided to take it to a new level. And in that partnership, we created notable centers of excellence, which are really sort of bastions of research, clinical excellence, and teaching. And we focused in 4 primary areas, and those are pediatrics. Pediatrician to my left, I had to start off with pediatrics.
Well done.
Cancer care, heart and vascular care, and transplantation. And this has been a remarkably successful, collaboration between our institutions, and we've been able to recruit really exceptional sort of leaders, scientists, and clinicians. We're also building notable centers of excellence in orthopedics, and I think, Ms. Colbert, we're also in ophthalmology. So in addition to that, Montefiore is an integrated and regional sort of system of care. So over the years, we've built up, we're probably in about 150 sites through the Bronx and Westchester. And they represent, very comprehensive primary and sort of special outpatient specialty care, and those mostly fall under Dr. Racine's responsibility. But we also have lots of other different partnerships, and I know some of you are very engaged in sort of hunger and homelessness, but we're in some of the homeless shelters in the Bronx. We're in 20 schools in the Bronx. We have a very robust school-based health program, actually also under Dr. Racine at this point. Dental sites. We have a pretty good home health care agency that is in the Bronx and Westchester, as well as now we have actually, through the acquisition of the previous Sound Shore Health System, are really happy to have a nursing home back in our fold. We had one a long time ago. And similarly, we're quite happy to have back into our fold a nursing school, something that we had many, many years ago, and which we haven't had. And we're really excited about those opportunities to do that. So I think, as all of you know, there's a tremendous amount of movement in healthcare across the nation, and certainly in in this region as well. So I think we're seeing everywhere, like other disciplines as well, a real sort of move towards consolidation, and so I think that Montefiore has feels quite ready at this moment, in this moment of activity. We have always been a forward-thinking organization. We like to say that we were an accountable care organization before there ever was such a thing as an accountable care organization. So about 15 plus years ago, we started to enter partnerships with insurance companies so we'd be able to really wrap care around patients. And that was really the foundation of what we have done recently with the Center for Medicaid and Medicare Services to become a pioneer ACO. And I think that we have learned a lot over the years, and we're quite pleased with what we've been able to develop, which we consider to be sort of a high-touch intervention around patients, for whom sort of are in our system and are with our private practicing physician community. And the Pioneer ACO, which is one of the demonstration projects that was identified in the Affordable Care Act, we're very proud. We did quite well in year 1. We did quite well, and a lot of our achievements were in fact working with the private practicing physician community. 70% of the beneficiaries that we cared for in the Pioneer ACO actually had private practicing doctors, meaning that they weren't employed by Montefiore. They were actually, private practicing doctors. But it's really about, to our way of thinking, it's really about sort of alignment and coordination. And that's really going to be the key to what we hope is going to be a better healthcare system for all of us for the future. So about last year, we began the process to acquire the assets of the former Sound Shore Health System. That, as you know, that the Sound Shore Health System went into bankruptcy, and through the bankruptcy, we worked to do that acquisition of essentially what is the facilities. We assumed operations at the site in November in 2013, and as I mentioned before, also of the nursing school. So we're quite pleased to have had the opportunity to preserve the healthcare services for the community and also to preserve jobs. So we have a proven track record. Well, let me just say one thing. So part of our, this effort of moving into these two hospitals was in fact to build on our footprint that we already had in Westchester. We've had a Westchester presence for many, many years. We have about 20 Westchester-based practices, different specialties, primary care, as well as we have recently acquired the former Kraft site at Tarrytown, which will be moving a lot of our, sort of employees to. So between Tarrytown and Yonkers, we'll have about 1,600 employees in that sort of swath, mostly back office materials. We bought a property in Mount Vernon to consolidate our laboratory space. The idea behind that is that we wanted to have all the clinical space we have be used for clinical space, and that anything we can do sort of off-site. So we're consolidating all of our laboratory services sort of in Mount Vernon. So we really feel like, Westchester is sort of where we are, and so this opportunity was sort of a natural one for us. So I think we see a lot of strengths and opportunities at the former Sound Shore Health System, and I think, Tony is really on the ground there in New Rochelle and would be quite prepared to answer sort of any specific sort of questions. But just so you understand sort of kind of how we approached it, both in Montefiore New Rochelle and Montefiore Mount Vernon are two separate entities. We just completely dissolved the Sound Shore Health System. We felt that each of them had their own unique cultures and strengths, and we wanted to sort of work with them distinctly and not sort of keep that umbrella that was linking them before. So that was a commitment we made. Montefiore has a history of being able to actually rejuvenate struggling and or failing hospitals. What was our former Lady of Mercy in the northern Bronx, what we now call our Wakefield campus, was a hospital that was failing. And we've been able to, over time, really kind of restore a kind of vibrancy to it. It had really been depleting and weakened for some time. So we have made, strategic investments over the period. There are now more employees there than there were when we actually sort of took over the site. And importantly, we're investing in new programs that probably 7 years ago when it happened, we wouldn't have necessarily thought would be there, because that's part of kind of how we approach it. Is you get in, you go in, and you see what the community needs are, what makes the most sense, where are the strengths. I'm sorry. Sure, sorry.
And don't fade off
Just so you understand, the problem is the ambient noise from the rest of the diner. It's very loud back there.
Thank you, I appreciate that. And the problem is also that I'm a soft-spoken person. I appreciate you blaming the restaurant. So what I was speaking about was sort of our experience with, this is much, I can see this is better, sorry about that. So our experience with what was formerly Our Lady of Mercy, now is our, Wakefield campus, and sort of just how we had been able to, over a period of time, 6 to 7 years, really start to build up, to work with the community, identify what are the best sort of programs, what are the right investments to be making in those areas. And we're happy to say that there are now more people working there than there had been working before, and that it's vibrant. It's very vibrant. So on that note, I'm going to tee it up. I'm going to turn it over to my colleagues. and Dr. Racine will speak. Oh, you're gonna
I'm going
stand.
to stand up, if it's all right, just so I can actually see people in the back and that they can see me. I have a daughter who doesn't hear very well, and she has hearing aids, and it's easier for her to hear what's going on if she can actually see the person who's talking. So this is for my daughter, and actually that's a segue to just full disclosure about what I know about Mamaroneck and the community around here, and that is that. So I have two daughters. They're older now. One's 25, one's 23. But for most of my recent adult life, they played soccer. We live in Manhattan. And so routinely we would come up to this part of Westchester so that the teams from Larchmont and Mamaroneck could beat the stuffing out of my children. Soccer. It was a painful, terrible part of my life, and I owe it all to this community.
So you're into sports medicine?
Right, yeah. Well, I was then, right? I'm not so much now. No, actually, it was, you can imagine, it was a revelation from those of us from Manhattan to come up here. I mean, the fields are just gorgeous. Everything is beautiful. It was a real education. Anyway, enough about my daughter's sports. So, I think, Ms. Richmond has set the stage exactly right for what Montefiore is about, and I think it stems from a couple of things. One is the institution itself and its relationship with the Albert Einstein College of Medicine, which I'll talk about in a second, but also its history. So the first part of that is we have a mission statement, like most hospitals do, most large academic medical centers, and that mission statement is relatively straightforward. It's to heal, to teach, to discover, and to advance the health of the populations we serve. Now, you can sort of figure out what the first three are about. It's about teaching, about being part of an academic center, and it's about giving good care. But that fourth part about advancing the health of the populations we serve is something that we do a little bit differently than some of our sister institutions around this region. And that gets back to the first part, which I was going to talk about, which is the history of the institution. So Montefiore, as you know, started out as an institution for chronically ill folks, and it moved to the Bronx about 100 years ago. During the course of its tenure in the Bronx, it's had a series of different leaders, all of whom, if you go back and you read Ephraim Bluestone, who was the president of Montefiore from the 1920s to the 1950s, or Martin Cherkassky, who was president after him, or Dr. Safier, who's currently president now, they have this abiding sense that if you're going to take care of people's health, you really have to know about the social fabric of the communities in which they live, because that's where people's health begins, and that's where disease actually begins. It's not so much what we do as physicians, it's the lives that people live in the community. So a lot of what Montefiore has been about for a long period of time has to do with its concentration on the social origins of disease. And that has led, over a period of time, away from what is the traditional way medicine is practiced in the United States, which is kind of a transactional fee-for-service relationship between patients and physicians. And what Montefiore has explored over the past 20 years, and is now actually rather adept at, is a different kind of relationship with patients and physicians, and that is to have as many people as possible in a situation in which we're responsible for all of their care. We're responsible for the risk to make sure that people stay healthy. And what that does is it changes the incentives completely from doing more and intervening more frequently, more intensively, to moving back to where people begin to get sick and say, okay, what can we do in that arena to keep people well? And the more people that you have in that kind of a situation, the more people you have in that sort of an arrangement, the better you are able to do that. It's very difficult to take responsibility for a population of people and to take risk for them if you're only taking care of 1,000 people. And that's just the way it is. You need lots of people in a system in order to be able to spread the risk around and to do this successfully. So what looks from the outside, as an interest of Montefiore's in just acquiring hospitals, really is not what this is about. What our strategic vision is for the Bronx and for Westchester is to have lots of people in the system in which we can take care of all of their healthcare needs. In order to do that, you need hospitals, you need, the kind of things that hospitals do, but you also need partnerships. And those partnerships are with the private physicians in the community who do all of that work. And those private physicians are both primary care doctors and subspecialists. So we pride ourselves on this ability to create those kinds of partnerships to make it work for everybody. Now that's one part of it. The other part of it is that the hospitals themselves have different relationships when you have large systems like ours. There are sister institutions that are interested essentially in taking high-end care from some of their affiliates and bringing it to the mothership, as it were. But at Montefiore, we don't really have much of an interest in that, only because we have more patients than we can possibly handle, at the Montefiore sites where they already are. There are certain things that happen at those Montefiore sites that just don't happen in most community hospitals. When you're talking about heart transplants or liver transplants or very, very high-end complicated things, that's a different order of magnitude, and there's nobody that's going to suggest that most community hospitals are going to do that kind of work. But most folks don't need their hearts transplanted, thank God. And the kinds of stuff that they do need can be done in community hospitals. So one of our objectives, and Ms. Richmond alluded to what our experience has been, for example, at Our Lady of Mercy, is to embed in those institutions the kind of work that really belongs in those institutions, and to leave it there and to strengthen it, and to make sure that folks who live in that community can go there for that care and don't have to travel, 15 miles someplace where they don't need to be. So part of our interest in all of this is to look at what the needs of the communities are, look at what the needs of the physicians are. I mean, one of the things I've been doing the past few months since we've been involved at Montefiore and Rochelle is to go around and talk to the primary care physicians in that area and say, okay guys, what is it that this hospital needs to be doing that it's not doing now from the standpoint of you and your patients, and what can we do to try and make sure that those programs get started? Dr. Safier is fond of saying, if you were to look back in 2008, when both St. Vincent's Hospital and Our Lady of Mercy, which were the two hospitals in the Archdiocese of New York, were both in trouble, and you were to ask somebody to put down a bet as to which of those two institutions was going to survive, St. Vincent's in Manhattan or Our Lady of Mercy in the Bronx, you would be crazy to think that it was going to be Our Lady of Mercy. And the reason that that has thrived is exactly for the reasons that Ms. Richmond was talking about, because when we became involved in Our Lady of Mercy, we saw lots of potential in terms of what could be going on there that wasn't. Right now we have our mobility center there. All of the orthopedics and rehab medicine has been shifted over from the Moses campus to the campus at Wakefield, because it's a need that was seen in that community, and it's a terrific use of those resources and facilities. Well, we see similar kinds of opportunities at Montefiore New Rochelle, at Montefiore Mount Vernon, and what we're in the process of doing now is discussing with the community physicians around those places what we can do and what they think would be helpful in terms of strengthening those institutions. So, I mean, I could go on and on about this and the plans, but I think more importantly is for us to sort of hear from you folks about what it is that you're thinking about. And as Ms. Richmond said, we're interested in this kind of dialogue. And the dialogue is not me sitting up here and talking to you. The dialogue is to hear about what it is that you folks envision in terms of the institutions here and how Montefiore can be a part of it. So
For the questions, because that will go to their television set. I'm just telling them to shout so that they can.
Can you hear me with this? No. So I have to shout, apparently. So why am I holding this?
This goes to the television, so we want to make sure that in the rebroadcast, every question comes through to the viewing audience of the television program. It's a little complicated. So we'd like you to ask your question through this mic, and if we can't hear, we will repeat it, okay? Yes.
Yeah, I agree. Marlene just said that one thing that we do want to hear a little bit more from you before we start questions is about the relationship that you have with White Plains and what plans are there, because I'd say in this community we have as many people who have doctors affiliated with White Plains as with Sound Shore. Or, no, Montefiore New Rochelle, sorry.
I'm going to learn from my colleague, stand up and speak loudly. We have a letter of agreement with the White Plains Hospital, but the details of the relationship are being worked out. I think that what you've heard from us is our fundamental values around partnership, around approaching, relationships. So I think we just need to think about, there's really not a lot we can say about the White Plains Hospital transaction right now because it's still in the process of being worked through, but would, ask you the things that, Dr. Seen talked about in terms of local strength, in terms of, the value of working closely with the private practicing physicians, strengthening them, strengthening a regional sort of system of care, all apply to any sort of transaction we enter. So.
Raise your hand. Give him that. Let the questions go through this.
You want the
Yes. So that it's picked up by the television.
shout into the mic.
What's that?
Shout into the mic. I think
Shout
is
and the
cool.
mic.
Shout
Is that too loud? No, because I'm a good shouter. So you tell me to shout, that's dangerous. A family member of mine was at Sound Shore in New Rochelle about a year ago for some emergency surgery, and thank God the doctor who was on call on a Friday night was phenomenal and fantastic. But through that process, which went on for about a week or two, I was impressed both by the quality of the personal medical care, and mind you, this was before the merger, but also the deterioration of the physical plant and some alarming concerns I had about physical security in the building. So I'm just sharing this as feedback. I realize it's early in the process. It seems like they have a phenomenal team of medical professionals and caring, devoted staff, but the paint seemed to be peeling off the walls, and there was just a general sense of deterioration. And I'm just asking what your thoughts are on that whole topic. And I could be wrong. It could have just been my observation.
We knew an attorney would be able to. No problem. When Montefiore came in November, one of the things that we were very cognizant of was the staff at Montefiore not only worked at Sound Shore, and now was Montefiore New Rochelle, but they were also members of the community. So it was very important for us to maintain the individuals who were working there as well as the physician community. And what we're doing now is just helping to strengthen the quality of medicine and clinical delivery. But relative to the facility, one of the first things that we did when we came in was to evaluate. There was a big due diligence process relative to the physical plant. And there were a lot of things that were deteriorating. A lot of things that you could physically see, like paint on the walls. Then a lot of things you couldn't see, like fire alarm systems that were non-functional. The HVAC and heating systems were located external, out in the parking lot as opposed to being within the plant. And there was an initial investment of over $20 million into the actual physical plant. I think you would be very pleasantly surprised when you come in now. We still have a lot to go. We're looking at those service lines that we want to deliver for the community and where we would expand. But relative to the actual facility as it is now, it's had a total facelift. We have gone from unit to unit. We have painted. We have redone the floors. We've put new furniture in. It just looks that much better, and you really get a great sense of accomplishment when the employees tell you. Dr. Safier was out last week visiting, touring as he often does, just to get a measure of the morale, and the employees were just telling Dr. Safier how happy they were to be working there again, that the place was bright, there were lights, you could see, and it was just a great environment to come into. So if you do come by, you just come by to visit, I think you'll be very pleasantly surprised.
Yeah, could you it's a little puzzling to me in this era. It's a little puzzling to me in this era of constrained resources how a nonprofit institution like Montefiore is able to expand and take over physical facilities and all of these burdens. Could you share with us what the financial model is of Montefiore and how it will allow you to sustain your position and improve our position with the resources that will be available to you?
Did you all hear that question? Okay. Do you want to repeat it?
I think the question is, how can we afford to do any of this?
That's the question.
I mean, did I get that right?
Yeah.
Right, and so I think the short answer is that in a fee-for-service environment, you probably couldn't do this. The only way to do this is to be willing to take full risk for the patients that you take care of. And over time, the numbers of patients in the Montefiore system for which we have full risk has grown and will continue to grow. And the reason for that is just what I was saying before. There are two reasons for doing this. One is, if you think about it just from the standpoint of how you would ideally want decisions made for medical care, what you would want is the people who are having to make those decisions should be the same people who understand what the financial risk is. And essentially those people are the patient and the physician. Those are the folks who have the greatest concern about what's going to happen for any decision. And you want those folks to understand what the financial implications are of any clinical decision that they make. Well, the way to do that essentially is to take the risk for whatever's going on in a healthcare environment and to have the providers have some share in that risk so that they are cognizant of what the financial implications are. And to share that with their patients.
Can you explain what taking the risk means? Because I'm not sure everybody understands that term.
I'm sorry. Absolutely. So what it essentially means is making what the insurance company does. So what does an insurance company do? Insurance company says, okay, well, everybody in this room, we're homeowners and we're concerned that we want to make sure that if something happens to our home, we get reimbursed for it. So we're all going to kick in some money. We're going to call that our premiums. It's going to sit in a pot over here. And thankfully, most of us are never going to need it because our homes are not going to get damaged or burnt down. But maybe my house will get damaged and burnt down. So all that money, that's that premium, is going to go to pay for my rebuilding of my house, right? That group, we are, as a group, assuming the risk of all of us. That's what we're doing. That's what the insurance is. It's putting all the risk together in a single pool and then redistributing that to the people who end up needing it. And that's exactly what medical insurance is. Essentially, everybody pays their premiums. And when someone gets sick, the money that's coming from all of those premiums gets diverted to the sick people to take care of their medical care. Well, that's what insurance companies do. But you can have those same decisions and all of that risk given over to the provider itself. So the hospital can say, okay, rather than the insurance company taking all the premiums and taking the risk, we'll take most of the premium and we'll take the risk. So the insurance company doesn't have to worry about it. Anything that happens to the patients that are under our purview, whether it's a cold, whether it's nothing at all, whether it's open heart surgery, we will pay for because we're going to get all of the premium. We're going to be the insurance company, essentially. And if you do that and you know how to manage people while they are well, you can make that pay for itself, essentially, which is really what it's about. What you do is you take the risk for a large number of people, and all of those premiums take care of the folks within that pool who get sick. But you spend an awful lot of time making sure that people get their Pneumovax vaccine, making sure that people get their colonoscopies done, making sure that folks who already have chronic illness like high blood pressure get their medicines done correctly, making sure that folks who have congestive heart failure are taking their medicine. And by managing very intensively folks who either already have chronic disease, who might develop chronic disease, you can save money in the system. And if you save that money by keeping people well, you can use the money that you saved to invest in other programs. And that's essentially the way we're doing this. And the reason why we've managed to do it so well is that we've been doing it a long time. When Ms. Richmond was talking about accountable care organizations, this is simply the federal government all of a sudden deciding a couple of years ago, it's a good idea to do it this way, actually give people who are providing the care a chance to share in the risk and save money. Well, we had spent 15 or 20 years developing a system to do that. We have a very elaborate care management organization. What's that? That's a group of people, mostly nurses and care managers, 800 of them. All they do is follow up with patients who've been seen in the practices within Montefiore to make sure that the things I was talking about are happening. That people understand the medications that they're on, that if there's any complications, they know about it early, that they can communicate with their physicians about anything that needs to be done. And if you do it over time, you get good at it. I mean, we started out in the mid-1990s and we were terrible. We lost money for years because we didn't know what we were doing. It's not something that you sort of know how to do out of the gate. You've got to learn about it. And particularly for many of the patients that we are responsible for in the Bronx. These are folks that have very, very complicated and stress-filled lives. And to be able to have care management that works for folks like that is not a trivial undertaking. So the point of all of this is that there's a way to do this where there is a small margin that's created, and that small margin can be used to invest in other kinds of programs, and that's what.
If I could just add on to that, that there is, Montefiore has, in addition to what we're describing as some of these other core competencies, developed an incredible operational efficiency. And it has not been easy in climate to do as well as we have done since 2009. And we have decided, we have kind of actually kept, decided to set aside resources for exactly these types of strategic investments. So everything that we are doing, we're doing sort of thoughtfully and evaluating, with preparation and evaluating the risk, but particularly evaluating the benefits to us for the future.
I want to reiterate that, and I'm sorry that I didn't bring it up, that's why Ms. Richmond is here to make sure that
I'm okay, thanks.
do the right things with regard to that. But it's true that, the overall design that I was talking about is important, but what's as important as that is that the supply chain, the revenue cycle, the financial agreement, all of those operational details at Montefiore are extraordinarily well run. I mean, extraordinarily well run, and you have to, if you're living in a situation in which 80% of the patients that come to your institution are being paid for by Medicare or Medicaid, you better know what you're doing operationally in terms of making sure that you bill correctly, collect correctly, order the supplies that you need correct, all of that. And I have to say that the folks at Montefiore who do that are really, really good at what they do.
Good morning. I mentioned earlier that I'm with the Larchmont Mamaroneck Hunger Task Force, and we run a food pantry where we distribute food to about 380 families every other week. It's about 1,500 people. Among those 1,500 are over 400 children. Coincidentally, at 10 o'clock this morning, I'm meeting with a representative of Montefiore, New Rochelle, at our food pantry to talk about an initiative that I'm very interested in, and that is some sort of nutritional education program. Because for those of us who work at these pantries, it's very clear that nutrition is an important topic, and it sort of speaks to a little bit to what you were just saying, that if you keep people healthy and they get good nutrition, that's going to reduce medical costs and other just health issues in general. And I was just wondering if any of you have anything you want to add. Of course, I'm going to be meeting with one of your colleagues this morning to hear her suggestions about how we can get this information to our clients.
Did everybody hear that question? Yep. Okay.
I mean, I don't think we have anything to add because, I'm not sure who are you meeting with?
Iris Rosario.
So,
Iris, good friend of mine. She's the head of the WIC program.
I'll tell her you said hello.
She's fabulous. This woman is a dynamo. If you haven't met her,
I've met her.
She's amazing. She's amazing.
Good. Now, I'm glad to hear it.
Oh, yeah.
Iris was with the Sound for Health System before. So we're really lucky to have her part of Montefiore now. So I will say that these kinds of conversations like you're having today, the conversations that Lynn and I have had about aging in place, these are the kinds of conversations we have across our region every day. We have hundreds of partnerships and trying to figure out how we can leverage what we know and what are our expertise with what's the expertise and the strengths of local organizations focused on whatever particular issue is they're focused on. Because we really do believe in that spirit, 1 + 1 = 5, and that wherever there are ways that we can kind of help and partner, we look to do that.
You have to shout.
We applaud the community spirit. We're wondering, we have more undocumented citizens, what is your ability to deliver health care to this group?
Did everybody hear that question? It's the ability of the system to deliver health care to the undocumented residents.
So I'll tee that off and weigh in. I think that one of the, obviously for the Affordable Care Act, which was, a very positive direction in terms of insurance expansion, left out the undocumented. And in New York State, there's the ability, if somebody who's undocumented, and what we would call uninsurable, because Montefiore has a pretty robust process for enrolling eligible people in Medicaid. So we really, we've tried to really move on that level. But for the uninsurable, which is really the, primarily undocumented, I think there's a tremendous opportunity. So New York State pays for hospital care, ironically, but doesn't pay for, the things, the care that will, I think to Andy's point earlier, what you need to do to keep people out of the hospital. And we all know that winding up in the emergency room is infinitely more expensive than it is to really be able to take care of some particular conditions in the community. So I think we're all looking for opportunities to think differently about this through partnerships, through potential, government-related sort of projects. It's just it's a hot button political topic. There seems to be a real hesitancy to really start to think about how to embrace access to primary care for the undocumented.
Montefiore also runs a series of federally qualified health centers, FQHCs, where many of the folks who are undocumented come and get care because it's something that the federal government will pay the center to do. And we also have other FQHCs within the Mount Vernon region and other places that we're partnering with to make sure that we can get as many people as we can into those services. Part of the problem, as you probably know, is that folks who are undocumented are very reluctant to engage in the system because they're worried about essentially their documentation status, right? So, it's interesting you mentioned Iris because Iris is very interested in the immigrant community, particularly in Mamaroneck. And she's, mentioned to me that there's a big opportunity there. So I think using folks who have contacts within the community to get out to people who might not otherwise engage in the system is going to be part of what we're going to need to do.
I'm sorry.
Just for clarification, I was unsure about, two things, basically. One is when you mentioned about spreading the risk around, and then, I think about the term managed care. Is it possible, actually, within the community for, let's say, an organization like Montefiore to actually replace an insurance company? So I wasn't sure what that meant, as far as spreading risk. And my second thing is, I've always wondered, what do you call these? What's the difference between an organization like WestMed and what they do and what Montefiore does? Just what those two operations are.
So I think the WestMed is a physician practice. So, and we have a good relationship with them. We are an integrated system of care, so we're hospitals, we're home care, we're nursing care, we're primary care. So I think if that's the gist of the question about the difference, there's clearly sort of, they are a comprehensive, essentially ambulatory care. And again, thinking about that our interest is really in partnering with organizations like that and partnering with even the smaller, private practicing physician community. I think the notion of risk and could Montefiore replace an insurance company, and I think we all have a bad taste in our mouth about what the 90s saw as managed care. And from our perspective, and even at that time, we saw that as essentially managing price, and that it was really a barrier. And I think really what's interesting about, and what we like about right now, is that the opportunities to actually have the upside through alignment and coordination, so that it's not, the whole gatekeeper model of managed care didn't really yield any good outcomes. So we really feel like you can, if you actually really start with the patient and you're coming at it from the point of view of a provider, you can do a lot to actually have a benefit to cost as well as a benefit to quality and outcomes. And I think that's really, we don't see that you can have one without the other. And could Montefiore be, replace insurance? I mean, whether it's an insurance company or whether we take risk from the insurance company, it doesn't matter. What matters to us is it's a provider-based approach, and you align the incentives in the right way.
Right. The only thing I would say about it is Montefiore is not replacing the insurance companies. The difference is that in a normal relationship or in the old relationship with an insurance company, if you're a provider, well, here's a perfect example. If you're a primary care provider in the community, actually, you have a contract with the insurance company, but it's a contract sort of in name only, in the sense that they come to you and say, here's the contract, sign this. Okay? And you sign it. And essentially what it says is that we'll pay you this amount for a throat filter, and this amount for this, and this amount for that. And you have no leverage. So what normally used to happen with the relationships providers and insurance companies is that the insurance company would get a premium. They'd take 20% off the top, sometimes more. And then they'd first start to negotiate with you with the remaining 80%, how much they were going to pay you, how much they were going to keep. What Montefiore has done with its relationship to the insurance companies is, wait a minute, how about this? How about we take 95% of the premium, but then we take all the risk, so that you don't have to worry about paying anything. Just, we'll take most of the premium. You keep a little bit for administrative purposes. But we take all that premium. And then anything that happens to the patient, we're responsible for. Because we know that as providers, we have a better sense of how we can keep people healthy than you ever will. So let us take the premium, and let us take the risk, and let us manage patients. And that's really what we're trying to do.
Just to add one thing about that, because I feel, I'm sorry. If you can imagine right now in the current, what they call, who can pay for what, like the fee schedule. So we all know that social workers, that psychologists, that health educators, that these are all part of a healthcare team that really bring value to the patient. And right now, in the traditional model, those services weren't reimbursable. So there's really no incentive to sort of set them up. And so I think really what we try and do is the value proposition here is that if you're not beholden to that reimbursement schedule that you get, however your money sort of comes in, you can hire these people because you know they're going to make a difference. Again, not just in cost, but a difference in quality and outcome for the patient and experience for the patient. You can do that. So I think that's sort of another sort of dimension to even just the physician-based approach is all the other members of the team who really add tremendous value.
So how will it affect various physicians? It may not affect physicians at all. I mean, we're going to be, as Ms. Richmond was saying, we have partnerships that we've established with WestMed. We invite any physician who's going to be in the catchment area of where we have activity to join our IPA. What's the IPA? It's essentially a group of physicians that where we can do the contracting for them, and we can get relationships with their insurance companies that may be more advantageous to them than they might otherwise be able to get. And we can invite them to be part of a shared savings arrangement, which means that if they can take care of their patients with our help, with our care management organization's help, in a way that saves the patient money and saves the system money. They get to keep some of that. There are a variety of different kinds of partnerships that are available to folks. But mostly what we do is we talk to different physicians and physicians groups and ask them, what's going on and what do they think is going to be helpful for them and how can we be helpful in terms of partnering with them. And depending upon what they say, we arrange different kinds of things. So it's sort of fluid and it depends really on the particular needs. There are some places like WestMed that have large numbers of physicians, well organized, and know sort of how they manage their care and stuff. And in some opportunities we can partner to put our own physicians in their areas so that they can help make that care a little bit more efficient. For others who are not in large groups like that, who are single practitioners by themselves in the middle of the community someplace, the relationship that they have with us might be different depending upon what they'd like to do. But we're really, at this stage now, just mostly talking to folks and asking them what would be in their interests so that we can be as helpful as we can.
And just to build on what Andy's point, there's no, for example, in our RRPA, it's only upside for the physician. There's no downside. So I think that's just an important thing to understand, that if this is something that a private practicing physician wanted to do, there's no sort of risk. So it could be like an absolute sort of steady state. But clearly, as an academic health system, we do specialty, subspecialty care, and that's a big part of who we are, and it's a big part of our overall model. So I think when we talk about sort of opportunities and seating Montefiore physicians, it's really in those very difficult to recruit subspecialist area that we're talking about that really are always better closely tied with an academic health system like ours.
What is available at Montefiore Sound Shore right now in the area of palliative care?
What is available now in Montefiore, New Rochelle, in the area of palliative care?
Well, we've maintained the palliative care team that was in place at Sound Shore, so we have palliative care both on the inpatient perspective and outpatient. We also work in conjunction, part of the campus is the Safer Extended Care Facility. So if in fact palliative care goes to the level of hospice, we have hospice care as well.
How many doctors are involved in palliative?
I would estimate that probably in total there's about 8 to 10 doctors who are involved.
For many of us, Montefiore New Rochelle is the place where we go in terms of an emergency. There's not a lot of choice when that situation comes up. And I just wanted to ask about the emergency room and what kind of plans there are to make that a place where we would want to go.
Yes, we really want to go.
There's nothing we can do to make an emergency room a place you're going to want to go.
Cocktails.
We would not want to avoid under any circumstances.
Right.
Yeah, emergency rooms referred to as one of those safety net services that every community wants to have, wants to know it's there, and wants to have the highest quality. Our focus, our initial focus coming in to New Rochelle was basically to stabilize the workforce. The workforce had gone through a lot of trials and tribulations, going through bankruptcy, et cetera. I think we've done a good job of doing that, making people feel comfortable that they have a good position, they're working for a good organization. The area we focused on immediately was the emergency department. So what we did was go in and do an immediate facelift in the emergency department, just based on the physical environment. And then what we're also looking at, and we've enhanced, is the number of practitioners, be that physician and or physician extenders and or nurses that are down in the emergency room. Because obviously one of the things that we all dislike about going to the emergency room, on top of the fact that you're going to the emergency room, is when you have to sit there and wait. And you get triaged, and then you're sitting there and you hear the stories of people waiting an hour and a half before someone got to them. So, we're focused on that throughput. We want to make sure that people get in, that they're seen immediately, that they're triaged immediately, that we know the more emergent patients get to be seen right away. And then we have what's also called a fast track for those people who come in who are, it's sort of a treat and release. They need something taken care of, maybe they broke a finger or something of that nature, but we know that that person's not going to end up in the hospital per se. So longer term, what we are looking at is an expansion of the ED. There were plans that were drawn up a few years back. We're taking a look at those plans, but again, a major commitment to the community is that you want to feel that you have a very high quality ED that you can go to and don't have to travel another 15, 20 minutes to go to an ED that you feel comfortable in.
Just to dovetail on the emergency room, I've spent a lot of time in all the hospitals because I have kids and who play sports, and I have to say that New Rochelle, while the staff was great, that idea of being sidetracked and waiting for hours did happen to us a couple of times, and for children, there was no TV, no warm environment. It was really, Greenwich is a good model if you want to see how kids can feel comfortable while they're waiting in the emergency room. But I'm glad to hear there's some plans for expansion because it really is not a warm, fuzzy place at all. My question is about quality healthcare flight, which occurred before this merger and acquisition happened. I happen to know that like one of the doctors that I used, because of the uncertain nature of Sound Shore, New Rochelle, whatever we call it today, hospital had already left. How are you going to attract some of those doctors back so that us patients will have them convenient again? And are you doing anything in that regard, or what's your plans in terms of quality doctors?
I'm going to turn this over to Dr. Seam, but I will say that we have a really nice pediatric ED at Montefiore.
So I think this is a really important issue, and it begins in a couple of places. One is actually with the physicians that are still there, and that's why I've been having these discussions with the internists in that area and the OBGYN doctors and the pediatricians. But essentially what's going to attract people back to the institution is changing the institution itself, right? And that involves some of the capital investments that Mr. Alfano was referring to, and programmatic investments. Physicians are attracted to institutions where they think their patients are going to get good care, and our responsibility, having just come into this new institution, is to do two things. One is to stabilize what was essentially a deteriorating sort of environment. But the second thing then is to repurpose things and to rebuild programmatic structures that are going to attract physicians back in. A lot of that happens, interestingly, word of mouth. That is, physicians in the community talk to one another, and the primary care doctors talk to the subspecialists talk to their colleagues, surgeons want to make sure that the operating rooms there run smoothly and efficiently, and they can get their patients well taken care of before and after surgery. All of those elements. I mean, we run hospitals. We know what doctors like in those institutions, and so we're going to need to pay attention to all of that. And then there are other kind of synergies, so that if you pay attention, for example, to the OBGYN services in an institution, that's actually extremely important from the standpoint of a community for those, obviously at childbearing age, but that has spillover effects to pediatrics, right? If you have a robust OBGYN service, that's going to enable people who have given birth there to want to bring their children there if you have a robust pediatric service. So each of these things is interconnected to all of the others, and we have an idea about how to get that done.
Thanks. Hello. As the town supervisor in the town of Mamaroneck, we run an emergency services department, as do most municipalities. And I wondered if you had any specific outreach plans or actions with the municipal emergency services.
Yes, we've already done that. We met with the head of, and
forgive me, I don't know the details. The head of the Westchester Emergency Services, the county emergency services, and it met with some of the local municipalities, but we'll continue to do more.
As a long-term Mamaroneck resident, I have never been aware, particularly of psychiatric services being a strength of the former Sound Shore, and I'm wondering if you have any plan. What are your plans, if any, for both outreach emergency services and psychiatric units, or is this something that you're not going to particularly grow?
So obviously, from an emergency perspective, we are capable and prepared to deal with any psych patient who is presented within the ED. Mount Vernon, our sister facility, does have a psychiatric department and does see psych patients. So quite often what we do is we will stabilize a patient within the ED, and then the patient will be transferred to Mount Vernon, where they have psych beds, as they say. Again, we are evaluating. That's one of the things that we're looking at relative to the service lines that are needed within the community. It's just been 5 months, so we need a little bit more time. We need more feedback, talking to groups like this in terms of what's really needed out there. But psych will definitely be something we continue to look at.
I think we probably have time for about one more question. You're on the right side of the floor this time.
For many years, my family would go to United Hospital, and I was wondering, for many years, my family would go to United Hospital, and I'm wondering if there was any chance of rebuilding a hospital at that location or near that location.
Not that, I don't know, not that I'm aware of. I've not heard that actual idea being entertained.
Okay, I think we'll have our last question, and then we probably should see if you can combine your questions.
I just have a quick question. In the event you have to go to the mothership, have you all looked at something about amount of time that people have to wait? Because that has always been an issue. And the other question I have is really, people spend a lot of time being frustrated with dealing with things like the building department. And I wonder if you've spent some effort on that, because that is a huge frustration for patients.
Did everybody hear that question?
Billing.
The question was the second part of the question was addressing people's concerns about billing. And the first part of the question was
really if you have to go down to, let's say, Monty or,
the main campus.
waiting time.
So I would just say yes on both fronts. There are two areas, both wait time, and I think wait time is an issue that actually affects every institution in the region, and I think billing is similarly, it's sort of an epidemic problem with healthcare in general. But that having been said, we are making, I've put it as a priority to figure out how to streamline the billing as much as possible, recognizing that you're working between the federal government, the state government, insurers, it's all kind of crazy. But that having been said, I think we recognize the opportunities we have to improve the kind of interface with the patients. And similarly, wait time is an issue. We're trying to approaching it from different levels. But thank you for raising that. That's important.
Fran, you have the last question?
Thank you. I'd like to, we've been talking a lot about the physicians. I'd like to hear what Montefiore envisions as the changes that will happen in the way that nurses view themselves as part of the medical team.
You can approach this two ways. You can have the physician answer that question, or you can have the nurse.
Let's go for the nurse.
I wouldn't touch this question now.
No, but I think you should. I think you should touch. It's exactly. I think it's a the point is actually the way you should touch the question, because I think that there is, there was an Institute of Medicine report around the future of nursing that really spoke to the need to sort of advance nurses to function at the top of their license. And I think there's a tremendous opportunity for nurses to really be part of that. And institutionally, it's an area that we have also sort of identified as an area that needs our concentrated attention. So both, there's what is a nurse in a hospital and how does it function? The whole notion of team-based care, the whole notion of breaking down hierarchies. If you think about sort of the cockpit model and what's happened in the airline industry in terms of breaking down hierarchy and how that's improved patient safety, I think you have to really that's kind of how we need to be sort of thinking about, so really sort of advancing not just nurses per se, but nurses as part of the team, and I think that speaks to, Andy's going to take it from me in a second, so, that I think that's something that he can speak to, but also in the outpatient practice. What are the values and that the nurses can bring to all of us? That's different and complementary to their relationship with a physician, not necessarily substituting it, but complementary to it. So I think enormous opportunities. I think nurse practitioners are sort of a different can of worms, but I won't take that because it's a conflict of interest.
So let me thank you for that question, because that actually is an extraordinarily important question with regard to how quality is maintained and advanced within our system. And I'll give you a couple of examples. So in the medical group now, this is this large ambulatory network that Montefiore runs. We have 23 sites throughout the Bronx and Westchester. Each one of those 23 sites is now certified as something called a patient-centered medical home. And what that means is that there is a standard, a national organization, NCQA, that requires you to be able to do certain things in terms of how you take care of patients to be qualified as a patient-centered medical home. One of the things that you have to be able to do is to demonstrate that you have multidisciplinary teams that are responsible for the quality of care that's being delivered. It's not simply what the physician is doing, it's what the team is doing. And as Ms. Richmond is talking about, if you want to get quality done right, you have to actually have the nurses, because without it, it won't happen. I'll give you a couple of interesting examples. So we were doing this several years ago in terms of pediatric screening when I was back in my old role. And there were a bunch of different things that we wanted to do. For example, we wanted to make sure that all of the adolescents who come through the different practices are being queried about their sexual activity. And if they endorse being sexually active, that they're being screened for HIV disease, for gonorrhea, for chlamydia, all those good things. So we started out, trying to get everyone in terms of the physicians to do this, and we did pretty well. I mean, they got the screening up, to 60, 70%. But that was as good as we could do. And once we got a multidisciplinary team together, and particularly the nursing staff, you could take those screening rates from 60, 70% right to 95%. Because if you want something done, ask a nurse to do it, and it'll get done. You can't get the physicians to do it as reliably as you can get the nursing staff to do it. That's an outpatient example, but we're doing the same thing on the inpatient side. So for example, we have a quality initiative on the inpatient service that's being run by our Chief Quality Officer, Peter Shamanian, who's a surgeon. And one of the quality initiatives is to make sure that every patient who is at a certain level of severity, who's going to go for surgery, is first evaluated by a medical doctor for all of the medical problems that that patient has, so that the surgeon is aware of those medical problems before that patient ever gets to the anesthesiologist or into the OR. To get that done, essentially, the medical doctor has to see the patient, has to fill out a form. The surgeon actually has to read that and sign off that, oh yes, I understand this, not only that, but I actually talked to the patient about the risks and benefits given their medical condition. And all of that has to get done before a patient ever goes to the operating room. So, we talked to the surgeons, we asked them, we cajoled them, we, educated them and stuff. And, some of them did it, some of them didn't do it. So finally we said, okay, here's the deal. The nurse administrators on the floor will not send a patient to the OR. Will refuse to send a patient to the OR until these things are done. And once that happened, 85%. Now, you can imagine those poor nurse administrators would be getting these calls from these surgeons. What do you mean you're not sending my patient down to the, But we instructed and said, look, if you get a call like that, send it to Dr. Shimamian. All you have to say is, I understand that this is the policy now. If you have a problem, talk to Dr. Shimamian. Here's his number. But I'll tell you, the nurse managers were unbelievable in terms of their consistency in being able to enforce something like that, because they understood the importance of it for patient care, more even than the surgeons did. And so they were really good partners for the surgeons in terms of making sure that they could understand that. And gradually over time, even the surgeons are understanding that. So, you know, the role that the nursing staff plays in every element of the quality of care that's being delivered throughout the institution, whether you're talking about very high-end, you know, care in the OR, you're talking about primary care, is absolutely essential. Absolutely essential.
I think we've run out of time, and probably the welcome mat from the Nautilus. But I want to thank our panelists. It was wonderful and really informative, and we are very appreciative of your spending your time and educating us, and thank you very much.